Hi, my name is Mike Pishvaian. I'm an associate professor in gastrointestinal or GI oncology and director of the phase 1 program at Sibley Memorial Hospital, which is part of Johns Hopkins School of Medicine. In recent years, it's become apparent that we need to do more molecular testing for pancreatic cancer patients, both in the germline setting and for somatic tumor testing. And I'm going to talk a little bit about the difference between the two of those. Let's start with germline testing. Germline testing means testing for the genes that the patient was born with. And that can be tested either through a blood sample where you're testing the normal healthy blood cells, or through a saliva sample where you're testing the oral epithelium that comes with saliva. In either case, you're testing the genes the patient was born with, and what's being looked for, what we're looking for is a pathogenic mutation in one of the typical genes that can lead over the decades of life to the development of pancreatic cancer. We know many of these genes by name, BRCA1, BRCA2, but then there's a whole bunch of them that we don't necessarily know as commonly. For example, 2% of pancreatic cancer patients harbor a germline ATM mutation. And there's a number of other much less common germline mutations. Germline testing really should be universal, and the NCCN guidelines in 2018 did establish that every single pancreatic cancer patient should be tested for the presence of an inherited mutation. And there's two reasons for this. One, for the patient themselves, because some of the mutations that are being identified, particularly BRCA1 and BRCA2, now have therapies that are directly linked to them, as we know from the phase 3 POLO trial with olaparib. But in addition, germline testing may lead to what we call cascade testing, where family members and siblings and children can be identified that may also be carriers of these mutations. And we now have screening methods to try and prevent the development of, if not pancreatic cancer, although maybe that is coming down the horizon, then other cancers that are associated with these genes, such as breast cancer and ovarian cancer. So the more we test, the more we know, the more we're going to be able to prevent cancer in many of these patients. And I do want to emphasize one last point about germline testing. There was a study that looked at known BRCA1, BRCA2 mutation carrier pancreatic cancer patients and asked what percentage of them actually had a family history that would have predicted for the presence of a germline mutation. And 40 to 50% of patients had no discernible family history. So please don't use family history as a screening tool in deciding whether or not to request germline testing. Basically, every patient with pancreatic cancer should undergo germline testing for a pathogenic mutation. What testing labs should we use? Well, quite frankly, there's a number of them that are out there. I can't honestly tell you that one is necessarily better than the other. There are also in-house labs that are doing this at different academic centers as well. You just want to use a lab that makes it convenient for patients, tries to keep the cost to either nothing or a minimum to the patients, and will capture one of upwards of 40 to 60 to 80 genes that could be tested for germline mutations. As for somatic tumor testing, that is a whole different ballgame, because that's really looking for gene mutations within the tumor itself. And we know that all cancers, pancreatic cancer being no exception, harbor many, many mutations. In the world of pancreatic cancer, over the last 5 years, there's been multiple publications that have shown us that up to 25% of pancreatic cancer tumors harbor genetic mutations that can lead to specific therapies. These are what we call actionable mutations. And these actionable mutations may lead to just standard platinum therapy, but it could also lead to therapies that would not have otherwise normally been thought of for the typical pancreatic cancer patient. For example, 0.5% of pancreatic cancers tumors harbor high levels of microsatellite instability, or MSI-high, and these are patients for whom immunotherapy can be of benefit. Similarly, about 0.5% of patients harbor mutations or fusions, really, in the NTRK genes, and NTRK fusions can predict for a very robust response to the TRK inhibitors, larotrectinib and entrectinib. So, and there's several other genes that can be linked to specific therapies that may not have otherwise normally been thought of for pancreatic cancers. So again, looking to the NCCN, in 2019, the NCCN recommended that every advanced pancreatic cancer patient, those with either locally advanced, unresectable, or metastatic disease, should undergo somatic tumor testing to look for one of these actionable alterations that may lead to a specific therapy either off-label or in the context of a clinical trial.